Can everybody see that? All right, cool. So last week I present, or 2 weeks ago, I guess. Time is relative now. I presented on general kind of overview about different types of co-occurring mental health conditions that commonly presented in individuals with substance use disorder. And this is the follow-up presentation to that, and it's to help us start to understand a bit more about things that might lead to those disorders, but then also how do we treat these co-occurring disorders with some of our best evidence-based practices available. This presentation was developed by me and Dr. Himes, and we have no financial conflicts of interest. And so we're going to be talking about the evidence-based treatment, a bit about ACEs and social determinants of health, and then also a little bit about suicide prevention in addition to treatment. So to start off, I think as many people are familiar with who've been working in addiction treatment for a while is there's a lot of focus within our profession on this idea of these stages of change model, and that we're always wanting to view our patients through this lens of trying to figure out kind of where they're at with their readiness to change, and how do we push them just that a little bit further so that they enter a new stage, and what kind of interventions or what kind of motivational steps or tools we need to add to their toolkits in order to help them get to a place where they can be a better version of themselves, where they're feeling a bit more healed. With an additional consideration of this stages of change model with individuals with comorbid mental health conditions is that while we often in addiction treatment have individuals who are in a more of an action stage, wanting to work on their substance use, we often have people who are in a pre-contemplation stage with a different behavior. So an example would be someone that's presenting with an interest in treating their opioid use disorder with medication-assisted treatment, and they have a history of PTSD, or they're also using stimulants regularly or cannabis regularly, and they're presenting and they're saying, I'm good, I really wanted to work on this behavioral, this medication from opioid use disorder, but everything else, let's not touch that. And we as providers know that sometimes when we only treat one thing, the other stuff kind of creeps in and keeps people from healing the best way they can. So always be working on kind of multi-pronged, helping them move to that next level of change where they're at for the different disorders that they have. And this is a snapshot of the original Porcheska stages of change model steps, and it presents the information about the stage of treatment that each stage corresponds to, and the specific treatment goals and recommended treatment interventions for each of those stages. And we have these notes are provided as well, but I won't go into a ton of detail on this, but different treatment options that we have, different mental health psychotherapy choices we have can be used for different places where people are at. So in addition to considering an individual's stage of treatment readiness, we also have to consider the kind of complex interplay of their social determinants of health and how this may inform which treatments we select for them when we push them towards a different stage of change, and kind of the consideration of their overall interplay of the development of their mental health conditions comorbid with their substance use disorder. I talked a bit last time about trying to do assessment to understand, was this mental health condition existent prior to their substance use disorder, to try to know if perhaps as we treat the substance use disorder, the mental health symptoms will get better or they're going to get worse. Knowing a bit about the social determinants of health can also help inform our kind of general guesses about whether or not, as we treat the substance use disorder, the mental health condition is going to get better or worse. So things like the healthcare system, the stability of their home environment and their economic stability are major risk factors for recovery and recovery maintenance. We know that people who are homeless, people who don't have a good stable support base, generally don't do as well in either forms of mental health treatment or substance use treatment. So when we are introducing psychotherapy options or choosing which one we want to offer, we might consider this. So if someone is really also needing to work on building up their social support network, we might specifically select a psychotherapy module or mode of treatment that would encourage that piece in addition to working on their specific mental health symptoms. And another major consideration is that we kind of have been talking a lot about in this region of the country and more widely recently, is this idea of adverse childhood experiences. In addition to the kind of the present social determinants that are influencing things, there's also the long history of risk factors that each of your clients will present with that will influence success with treatment often, and could also influence which specific treatment you select. So adverse childhood experiences are really common. It's been reported that nearly 2/3 of adults have at least one. And there's the CUT score that they use is the idea that if there's 4 or more adverse childhood experiences, an individual's twice as likely to be a smoker or 7 times more likely to be an alcoholic. So once you kind of cross over to that threshold to kind of, I guess, 4 bad things having happened while you were growing up, you are going to have a much higher correspondence or range of risk behaviors. And this is relevant both to the patient that's sitting in front of you and kind of the childhood that they have brought with them, but also a lot of the people that we work with are parents, and they their substance use could be an adverse childhood experience that's presenting for their family, and consideration of that might inform a movement towards a more family-based model when you are selecting your psychotherapy. So what is our evidence-based practice for general addiction treatment? So in most addiction treatment centers, you kind of see a combination most often of these kind of 3 main psychotherapy modalities. So the first is motivational enhancement therapy, which is designed, usually you see that kind of at the beginning of the treatment, try to help patients kind of get on board with the treatment process, initiate change, kind of and guide them through the therapeutic process. That's a place where you really set goals and understand what that client is working towards. You learn about why they're choosing to get sober now, or why they're trying to enter a recovery model now. There's also usually cognitive behavioral therapy is a major component. So this is teaching clients skills to be able to get, CBT basically is teaching skills so that you can change your behaviors, your cognitions, and around your substance use disorder. And then the final one is the 12-step facilitation, and that's encouraging the treatment patients to engage more widely within the 12-step programming. And 12-step facilitation isn't necessarily directly the AA meetings, but it's teaching individuals how to best make use of that process. So how to find a good meeting for you, how to make sure that you can go regularly enough that it's helpful for you, how to get a sponsor, that type of step. And then also you will sometimes as well see with evidence-based treatment in addiction centers is motivational interviewing, which is kind of a one-off intervention to get people to change their motivations. And then cognitive processing therapy is for post-traumatic stress disorder. There's a renewed push and a great renewed push to involve families more often within treatment. There's one model of addiction treatment where we kind of send people off to inpatient for 28 days. They maybe have a family meeting or 2. They have often even limited access to their phones, so they're not able to text and call family members often. But there's been some good evidence as well that if we involve the families from the get-go and they're involved in each step of the treatment process, there's actually fewer relapses, and families feel more supported and like they are more able to heal. Because with the substance use disorder, there's often kind of a chaos within the entire family unit that's happened over the course of the manifestation of the addiction. And by everyone working together, you can all kind of work on that stress and kind of heal in concert from the damage that's been done by the addiction. Moving on to more specific treatment recommendations, depending on which co-occurring disorder an individual presents with. So for mood disorders, so this is anxiety, depression, bipolar-related disorders, we have a really good host of evidence-based treatments. Clients can kind of pick a couple different ones that they might want to try that would be best fit for them with equal efficacy. So CBT is often the frontline treatment option, but we also have good brief interventions as well as couples and family options that work well. And pharmacotherapy used alone or in concert with psychotherapy can have good evidence for some individuals. Post-traumatic stress disorder is incredibly common, high rates of this within substance using populations. And within a substance use sample, PTSD can be a really big barrier to maintaining recovery because of the intensity of PTSD symptoms that can come back up once the substance is no longer helping them kind of stay numb. And then also within a substance use population, there tends to be high rates of individuals who have experienced PTSD because of their drug use. So they are in risky situations more often and have more opportunity to kind of experience some of the things that cause PTSD. Even car accidents are a really good way to get PTSD, and if you're often driving under the influence, your chances of getting in a car accident are a lot higher. We have really good psychotherapy treatments for PTSD. There's not pharmacotherapy options don't have quite as much evidence base. But the kind of the two main ones that you'll see is prolonged exposure and cognitive processing therapy. EMDR also has an evidence base, as well as trauma-focused cognitive behavioral therapy. Insomnia is on the slide. This is a cross-cutting symptom to keep in mind for a range of mental health conditions, including those specific to individuals on buprenorphine. I've been hearing a lot of people talking about increased sleep difficulties recently with the pandemic, and just kind of the stressors related to that people are having. You're watching the news more often. That contamination bias is a really strong one within humans. It helped keep us alive for centuries when things weren't that clean and we didn't have antibiotics. So it really taps into that. So people are kind of staying up and having a harder time shutting it off because they're ruminating about things that they touched that maybe had COVID on it. So just be aware, check in on sleep, no matter what co-occurring condition individuals have. And we can treat and help people sleep better. There's some quicker fix options, including pharmacotherapy, and then there's some that take a little bit more training and a little bit more investment on the front end, but do have really long-lasting success, including cognitive behavioral therapy, specifically cognitive behavioral therapy for insomnia, which includes things related to changing the environment of sleep and controlling stimulus, not watching TV, not watching the scary, stressful news right before bed, as well as training and relaxation skills. And people can have specific sleep-wake disorders that are comorbid with their substance use disorder, or it can be a kind of cross-cutting symptom. So they could have anxiety and an anxiety disorder, and then also be really, really struggling with sleep that needs specific treatment additionally. ADHD is also a common co-occurring symptom illness with substance use disorder, we see that impulsivity piece, so is a highly transdiagnostic symptom, and often people have done some self-medication to help with their ADHD symptoms, and when we take the substance away that they've been using, they find themselves really have difficulty concentrating above and beyond symptoms of withdrawal. And you don't necessarily want to add on an additional stimulant to help with ADHD, and as a result, you can turn to cognitive behavioral therapies that can teach people specific skills around focusing and stimulus control again, and kind of modifying their behavior so that they are able to focus for extended periods of time. So this next treatment is contingency management, and we often have in our echo, we discuss about how do we treat co-occurring stimulant use disorders. A lot of our patients are also using methamphetamine, and we wonder, what's the best way to treat this? And there's research being done right now on medication-assisted treatments, but we don't have the best choices at the moment. So contingency management treatment, which is a treatment, it's based on operant conditioning, where you give people specific monetary reinforcements for engaging in specific behavior. So you pay someone to come in and give you a urine sample that's negative for a specific drug that you're wanting them to not use anymore. And this it's sort of like a token economy concept. So think back to grade school where you got stickers for listening to the teacher. Humans like to do things that are rewarded closely to what they just accomplished. It's hard to wait for the bonus paycheck at the end of the calendar year. It's a lot nicer to get your paycheck once a week and be able to spend it on things that are important to you. So this is that idea. So instead of saying, you'll get reap all these benefits from your sobriety in months and years later, it's here, you get cash right now. And it can change kind of the overall system of reinforcers. So if people can work for that immediate cash reward, they're able to then realize some of the benefits of sobriety. So they may find that their mother now invites them over to dinner because they're sober, and they reconnect with those social reinforcers. They're able to keep the new job that they just got because they don't fail their drug tests. So contingency management helps you start the sobriety piece. It doesn't necessarily keep you sober. The idea is that your environment will become reinforcing over time by having made that initial commitment. So we're not simply paying people to get sober, we're paying them to start that process and kind of help tip the scales, because drugs are really reinforcing, but so is money. The great thing about contingency management is that it seems to work well for all populations of persons. So there's no income effect, so across different SES classes, there's no racial effect. Some of our treatments tend to work better in white people because that's what we tend to do our research in. And then it also can be really effective for individuals with multiple treatment admissions. So people for whom previous treatment has not worked, they can sometimes do well with contingency management because it's so different from other things that they've tried. Similar to that slide on insomnia, another, this is kind of just a note to file, sort of to keep in the back of your mind, is that many of our co-occurring substance use disorders, co-occurring mental health disorders, have incredibly high rates of comorbid suicide use. So 90% of individuals who die by suicide have either a mental health or a substance use disorder or both. So whenever we have a patient who is presenting with a substance use disorder, especially if they're also having a comorbid symptom, mental health condition, we always kind of want to classify them in our mind as that moving into the more moderate to high risk box, where we may want to just blanket do safety plans so that they know what to do if they cross over into ideation stage. And specifically important with this is that the research data suggests that the time from thinking about wanting to kill yourself and actually attempting the act is often less than 3 hours. So if we are seeing people once a week, once every 2 weeks, once a month, the odds of it being within that 3-hour block before they decide to make an attempt and us being able to say, like, you can do this, let's make a plan, is pretty low. So we want them to have the skills to be able to know to call suicide safety lines, phone a friend, call the emergency room, because the risk of it being when we're not there is very high. The co-occurring risk factors that you look for, kind of the main ones are, you know, the general psychosocial stressors, trauma, adverse childhood experiences, minority status related to sexual orientation or gender identity, prior history of suicidal behavior produces future attempts, and then things that can help us feel a bit better, that people will be back at their next appointment, is identified reasons for living, strong social support relationships, religious beliefs, specifically if they're in a religious orientation where suicide's a sin, and involvement in support groups like AA is helpful. So what can we do to improve the outcomes of individuals who have comorbid mental health conditions in addition to their substance use disorders? So some of the main kind of evidence-based ways to make changes in this population is to do that continuous assessment for stages of change. So to understand, okay, they're ready to work on this disorder, they're not quite ready for this other one. Do I keep checking it and I keep trying to move them to the next phase? Continuous screening and assessment, inclusive of understanding adverse childhood experiences, those social determinants of health, understanding risk for self-harm and suicidality. Wherever possible, if we can start to include family in interventions, and understand where things are. I've heard people with the telehealth that you're actually more often like meeting family members because they're on the phone and they're like, hey, FaceTime, I'm holding up, hey, that's my mom. So that's kind of a cool thing that we're getting that window into people's lives that maybe you wouldn't see if they're just coming in for a 30-minute appointment. And then tailoring the interventions to meet the patient where they're at. So if they're willing to work on their opioid use disorder, but not quite ready to work on their methamphetamine use disorder, we're more likely to help them with their methamphetamine use disorder if they're coming to see us regularly. If we kick them out and say, don't come back, it's a whole lot harder to get them to change. And then another good evidence for the efficacy of engagement in mutual self-help groups, and there's some specific ones for individuals with dual diagnosis that can help. I don't know the availability of these in this area. There's not quite as many groups around here as there is in like New York or in Connecticut, but Jill shared earlier in this sequence, I think on the COVID section, there's like a list of all the groups that are offering online meetings right now, and there is that's what I got, those references, and stop share. All right, thanks guys.
Thank you, Meredith. Yeah, I did share a resource, and I don't recall if I managed to get that to you, Melissa, so you could post it to our resources section.